story of Microtech, which originated with stents, is about sustaining life. Microtech, your trusted partner.
Boa noite a todos. É um enorme prazer nós iniciarmos mais uma sessão das atividades da SOBED Nacional, na gestão do Dr. Ricardo Dibi e do Dr. Herbert. Essa noite nós teremos o prazer de poder estar recebendo o professor Paul Ackerman. Professor Paul Ackerman, ele é um médico assistente, professor da Universidade de Brown, nos Estados Unidos, e ele foi um dos introdutores da técnica de enteroscopia no mundo. Então, a gente vai ter o prazer de poder ouvir rigorosamente a pessoa que deu início a tudo isso. E para que tenhamos como moderadores pessoas que tenham a mesma expertise, nós temos o prazer de contar com a doutora Paula Poletti e o doutor Admar Borges, conhecido de todos vocês, que tem grande experiência na área da enteroscopia e na área da cápsula endoscópica. Hi, Paul. Thank you so much for your accept our invitation. And now, please, start your conference.
Sure. Okay. I'm going to share my screen now, and hopefully it will work there. Okay. So is the audio okay and you can see the screen? Is that correct?
Perfect.
So thank you very much. It's an honor to be here today. I have been down to Brazil several times, and I miss Brazil very much, and I miss all my friends. And in these times of COVID, this is the best we can do, but it is good to see all my friends and speak to them again. So I was asked to speak about errors in capsule endoscopy and deep enteroscopy and how to avoid them. My experience in this is I think reasonably extensive. We've been I've been running the Center for Small Bowel Endoscopy here at Brown for approximately 10 years now. I think that deep enteroscopy is one of the most challenging things that I do. I do most procedures, and I think it's challenging for multiple points of view, including the fact that it is sometimes very difficult to find the pathology, treat it, and it can be quite challenging and frustrating. So with that introduction, what I'm going to do is begin my talk, which I think will be approximately 20 to 25 minutes. So for my conflict of interest, I do consult with Olympus Corporation. I was the inventor of spiral enteroscopy, and that was acquired from Olympus, and I consult with them about spiral enteroscopy, the motorized version. So what I'd like to do is start with this, and this is, I think, if you are a referral center, you see this a lot. You often get requests to look in the small intestine for pathology, which may be usually the most common thing is bleeding. So one of the most important things is to make sure that you're looking in the correct place. And this, I think, happens reasonably often, where a patient is sent in with the diagnosis of small bowel bleeding, and in fact, that isn't the area that's bleeding. So you must always maintain a high index of suspicion that you are indeed looking in the right place. Lesions that can be missed during upper endoscopy and colonoscopy account for approximately 25% of our referred patients. So 1 in 4 of our patients who come in actually have a bleeding source that is not what they think it is. Now, this number is is often a little bit less than that if they've had capsule endoscopy with directed which is directing our enteroscopy, but nonetheless, there is a significant increase, significant amount of patients who actually have bleeding from the that are within reach of the upper endoscope or colonoscope. So, some of these things we see, as you know, are the Cameron ulcers, Cameron erosions, fundic varices, peptic ulcer disease, particularly the ulcers in places that are sometimes hard to see. I've seen several times where there's pyloric channel ulcers that were just not appreciated due to the constriction of the pylorus. Angioectasias are something that can often be missed. They can be missed for a number of reasons. One is just from the lower in the colon, just not having a really good clean out so that you cannot see, so you miss them on the surface. The other thing is sometimes angioectasias can, if the patient has a significant amount of sedation on board and the blood pressure drops, sometimes these angioectasias can be very difficult to see, so they're actually commonly missed. Doulatois lesions are, of course, something that we need to look for, particularly in those demographics, the 50, 60-year-old male, oftentimes who are smokers. The Doulatois lesions are something that we can carefully look for and occasionally pick up. The gastric vasculoectasia is something we see reasonably often, and sometimes this can be underappreciated as the cause for the anemia. Lower GI lesions we see most commonly that are missed are angioectasias. Doulatois lesions occasionally occur in the colon, and of course occasionally neoplasms. So one of the things I really want to encourage you to think about is that, what I say here is we must trust but verify, particularly with referrals that come in. These patients have been worked up, and we often see, so we are often concerned that the a lesion could be missed. If the patient is referred for a capsule endoscopy, we have a low index of suspicion, therefore, to repeat the upper endoscopy and colonoscopy. So we take a careful history and we make sure that we're looking in the right place. I always try to review the capsule findings. This is particularly true for what I call lumps and bumps. Usually the AVMs are pretty clear, but sometimes when they think that there's a submucosal mass, or some other lesion in the intestine, in the small intestine, I want to see that myself, because I think sometimes the people who are less experienced don't properly appreciate it. So to avoid mistakes or missing things, more importantly, the timing of capsule endoscopy is of critical importance. The Singh in 2003 did a study which showed that if you have a patient admitted to the hospital within 3 days of the admission, you should be doing the capsule endoscopy. And if you do that, you get a higher diagnostic yield and your therapeutic intervention rate and reduction, and there's a reduction in length of stay. In our experience, we try to get this done within 24 hours once we suspect a small bowel bleeding. This is sometimes challenging, but we usually get it at least during the week. You can get it within 24 to 48 hours. And we think our success rate at finding these lesions is significantly better. The other thing I'll strongly encourage you to do, and we found this to be quite helpful. Matter of fact, just before our meeting here today, I was just reviewing a case. Placement of a tattoo at the maximal point of insertion, I think, is important. Because what it allows you to do is, if you do not find a lesion that's bleeding or there's further bleeding, it's sometimes very helpful to determine whether you can go back in to find that bleeding, to treat that bleeding, and whether you can actually reach it. So we think the placement of a tattoo when we do our deep enteroscopy is of considerable importance. That tattoo can also direct whether we go antegrade or retrograde in our approach. So this here is just a little bit.
So there are a couple of ways to create reliable tattoos from a technical standpoint.
So what I'm going to do is just say here is that when you're placing a tattoo, I think this is important. If you are, what we like to do is, what you'll see here is raise a bleb with saline and inject the tattoo into the saline. This here, they're actually, I've changed my technique. What I actually do now is I inject as the needle is going in, I think you'll find that that actually helps you inject into the submucosa. So what I do now is I'll put the needle out, inject before. What we're seeing here is now we're going to inject, there's a bleb that's been formed, we're injecting tattoo into that. So I've altered my technique a little bit. If you inject tattoo directly before putting causing a bleb, then what you'll see sometimes is that you'll be injecting tattoo and it will not be causing a bleb. The problem with that is that is oftentimes going through the wall and into the peritoneum. So that's something you want to avoid. It makes it sometimes very difficult for your surgeons to find the lesion should they need a surgical intervention. So my recommendation is always place a bleb with saline, and then inject the tattoo into the saline. And I think you'll appreciate this as a little tip going forward if you don't already do that. So one of the best practices we have, and I think it needs to be spoken about, is the role of the repeat capsule endoscopy. In our center, we have a diagnostic yield on repeat colonoscopy of 35 to 75%. So roughly about half the time a repeat capsule endoscopy will find the lesion when it's bleeding. These are patients who we often tell, if they let us know that they're having black stool or suspected bleeding, we have to come in for as urgent a capsule endoscopy as is possible. And we find about half the time this repeat capsule endoscopy alters our management of these patients. So we think it's a very reasonable thing to do. Sometimes these bleedings can be quite vexing to find. We need to occasionally work very hard at finding these lesions. So oftentimes we'll get patients will come in, upper endoscopy, colonoscopy, and a capsule. That capsule may or may not have our definitive diagnosis. Our deep enteroscopy may not be definitively diagnostic, meaning occasionally we'll find AVMs, we'll treat them, but we don't know if that's the real cause of the bleeding. If the patient has repeat bleeding, then what we do is we have no hesitancy for repeating the capsule endoscopy to help us direct our therapy. If we also find patients have significant bleeding, meaning ones that have melena and potentially even hypotension or require transfusions, then we'll bring them in for a CT angiography. And this, of course, is superior to the bleeding scan for directing our therapy. We find this to be something we can actually get a little bit faster also, and is for us a significantly better way to go with CT angiography over the bleeding scan. So if we suspect a brisk bleed, then we usually go right to CT angiography, and we found this to be quite useful to helping find this bleeding. So one of the problems with capsule endoscopy is the incomplete visualization of the small intestine. You know, there's always a challenge when the capsule goes through and doesn't reach all the way. This is less of a problem now with the 12-hour capsules, but is still a significant problem. You know, this is particularly a problem in about 30% of hospitalized patients who have a small bowel capsule endoscopy procedure. So about 30% of the time, it will not reach the cecum in the hospitalized patients. So what we do is we will do endoscopic placement with this capsule system here. The capsule fits right into the end and allows you to place it post-pylorically. Occasionally, it can be a little bit challenging technically because it's a little bit stiff here. But if you don't use this, I think you should consider it. It's of significant value. Some people place it with a Roth net also, and that is also a reasonable way to approach it. Let me just see if I can not do something there. Good. This is also very useful in outpatients who are gastroparesis patients. If I have suspected gastroparesis, then I'll book patients for an upper endoscopy and place this capsule post-pylorically. So one of the problems is seeing the entire small bowel. You place the capsule and getting a good visualization of the entire small intestine. We do there is some people have recommended a 2-liter PEG solution. The studies have shown that 2 liters is roughly similar to 4 liters in the small bowel, and there is. In the literature, there's some moderate trend to support small bowel preparation. Not everyone does it, but it is a reasonable alternative, and I think overall has some benefit to getting a good visualization of the small bowel. Simethicone can also be helpful, and there's some data which suggests it's a strong recommendation with a moderate quality evidence. So if you really want to get a good look, particularly in those patients who are second look capsule, and you really don't want to miss anything, the 2-liter PEG solution and some simethicone can be very helpful to avoid missing lesions, which is a common problem. Speaking of missing lesions, one of the most disturbing things, I think, is the missed rate for small bowel lesions, including tumors, which can be up to 20%. This is something that has always distressed people who read a lot of capsule endoscopies, is the miss rate for tumors. I think that this just tells us a little bit about the limitations of the technology with the single-headed camera. There are some dual-headed cameras which I quite like, and actually we use the dual-headed camera. And my feeling is that this has a lower incidence of missing of tumors. So that's what we actually use here, is the intramatic double-headed capsule. So the other thing to be concerned about is false positives. False positives, I think, are sometimes from overreading, and I think the most common reason for overreading is having people who do not read a lot of capsule endoscopy. And I'll speak about this in a minute, but I think that having consistent people who read the colonoscopy, small bowel capsule endoscopies, who read a lot of them, is very helpful to standardize your practices and procedures. So the other issue with this, the limitations of the capsule, is it really doesn't give you a precise localization based upon, so what we use mostly is the capsule transit time to give an idea of whether we want to approach from above or below. And I'll go into that some more in a second. So what we do here in an effort to limit our, to improve our interpretation and limit misinterpretation of lesions seen on capsule endoscopy, is we have a small group of physicians who review the video capsule endoscopy. We think this helps reduce and standardize the video capsule endoscopy interpretation. And we found this to be, I think, quite helpful. We use the 75-25 rule for deciding whether to approach from an antegrade or retrograde. If the finding is in the first 75% of the small bowel transit time, we approach antegrade, that's from above. If the finding is in the last 25% of the small bowel transit time, we approach from below, a retrograde procedure. As you know, the most feared complication of video capsule endoscopy is the entrapment of the capsule in the small intestine. If you look at the data, the pooled retention rates for all video capsule endoscopy is about 1.4%. With the in upper GI bleeds, it's about a little less, 1.2. And for people with Crohn's disease who do not have a suspected stricture, it's about 2.6%. If you're suspecting neoplastic lesion, it's also at about 2% of those patients who are not known to have a stricture. So this here is just a video that we did of removing a capsule. There's also a stricture. We'll show you that above it. So here we'll just do the endoscopic retrieval with a Rothnet. This here was done with a spiral enteroscope. We can oftentimes pull that right out through the overtube, one of the advantages of the spiral overtube. I will digress a little bit just to talk about strictures. This is a Crohn's stricture here. This stricture was not known at the time. This is a relatively thin stricture with a mild amount of inflammation. You have to be careful with these strictures. The Crohn's strictures I've seen usually come in groups of 2 to 3. And then you see a little more inflammation here, another dilation. Anytime there's inflammation, you need to be very careful with your strictures. I'll go into this a little bit more later, but the perforation rate with strictures ranges about 3 to 5%. And that can be a real challenging problem if you perforate the small intestine. So our options when you have the capsule endoscopy are endoscopic retrieval, as you went there, surgical retrieval. We reserve surgical retrieval for when we see those patients who have known issues that would require surgery to also treat the issue. For instance, tumors or high-grade strictures, particularly those that are very long, that are long strictures that are non-amenable to endoscopic therapy. So we do have a lot of patients that if it does get stuck, we resort to conservative observation. We treat the inflammation if that's present. And sometimes the delayed passage may take up to months. The MRI they'll tell you, is contraindicated. There are in the literature several cases where the MRI has been inadvertently performed on patients with capsules, and this has not been a problem. There's been no side effects of having the capsule with the MRI, although it is generally considered contraindicated. So there you see the video capsule. So one of the things you can do with video capsule is to try to prevent that, is to do use a barium capsule, and I'll show you that in a second. Patients at risk for small bowel obstruction should be carefully investigated prior to the capsule endoscopy procedure. And a patency capsule is in those patients who you suspect may have a small bowel obstruction, but you're not sure. In those cases, we selectively use the patency capsule. Overall, this approach of only doing patency capsules in those patients who we suspect have a small bowel obstruction has proven to be the most cost-effective strategy. We don't do it in every patient. We only do it in suspected patients. And this is despite the occasional retention rates of the patency capsule that are false positives, and that happens about 1/3 of the time. This here is the patency capsule from Given, so this is their patency capsule. So what I wanted to talk about next was the issue of implantable devices, and particularly the cardioverter defibrillators, and the concern with video capsule endoscopy. Overall, the preponderance of the literature is that it is safe to do this, and we consider it safe here. The literature has and the testing has is, I think, quite overwhelming. So we go ahead and we use it in these patients freely, and we do not monitor them anymore here. I do want to mention that different capsules use different ways of communicating their information. The Given capsule uses radio frequency communication. That radio frequency communication is similar to cell phones, and is theoretically could affect the implantable cardiac defibrillator. One alternative, of course, is what is human body communication, which is intrametic, which uses the fluids in the body to communicate. So it does not use radio frequency communication, so it should not affect the implantable cardiodefibrillators because it doesn't. There's no radio frequency involved. And of course, then there's also the capsule cam, which goes through and you actually retrieve it, and that restores all the information on itself in the capsule itself. So that, of course, does not need is not a concern for cardiac devices. So so problems with video capsule endoscopy and cardiac devices. I think overall it's safe. If you still have concerns and have the availability to use the intrametric human body communication, that's an alternative. One of the things that we do see when you and you need to be careful about, and you will see this once in a while, is video capsule aspiration. These capsules are reasonably large, and a number of these patients are older with some illnesses. So, you need to take a good history. It is important to know whether the patient has a problem with swallowing. So I think that it's very important that you be careful with those people, monitor them well. Occasionally, it can be asymptomatic, but about 1 in 800 patients will have aspiration. So I'm going to talk now about deep enteroscopy, double balloon, single balloon, spiral. Unfortunately, I'm not going to talk about my most beloved subject, which is the motorized spiral enteroscopy. But it's yet to be FDA cleared here in the United States, and I think is not in Brazil yet. So we use the approach that if the pathology is in the top 75% of the video capsule endoscopy, we approach from above. Antegrade is better than retrograde in the diagnosis and treatment of patients with small bowel disease. 2/3 of the pathology is in the top 1/3 of the small intestine. Notes about the retrograde procedure: it's technically more challenging. Up to 21% of the double balloons fail at the terminal ileum for intubation. That's because the scope is very floppy and it's hard to get around the corner. A little clinical pearl I'll tell you is that if you perform a colonoscopy prior to the retrograde, this can be helpful to improving your terminal ileal intubation. It cleans out and straightens out the colon. I think is something I learned from my friends at University of Massachusetts, and we've adopted that. So we always perform a colonoscopy prior to the retrograde ileoscopy. Depths of insertions are much better from above than below. And the retrograde we reserve for those patients who have capsule endoscopy findings in the last 25%, or the radiological imagings clearly indicate defects in the distal small bowel. This just shows that if you look from above, this is an older slide, but if you look from above versus below, 2/3 of the pathology is found from above rather than from below. So the risks of deep enteroscopy are really similar in all the techniques, except for pancreatitis, which has been found more often than double balloon. Double balloon has an acute pancreatitis of around somewhere less than 1%, although hyperamylasemia is much more common and can be seen up to half of the time. Diagnostic enteroscopy has a lower complication rate. So if you're just doing a diagnostic enteroscopy and you're not going to do anything, then it has a very reasonable complication rate of between 0 and 1%. Once you start doing therapy in the small bowel, your complications start increasing significantly, 3 to 4%, up to 5% in some strictures, depending on the nature of the stricture. So other than pancreatitis, all deep enteroscopy techniques really have similar risk profiles. This is in our institution. When we initially started our program, we used to get a significant number of patients with ileus afterwards. We've reduced that significantly. We think we're down about 80%. We've done that with the following approach. Our time of procedure is significantly less. So the time that the small bowel is actually pleated onto the scope is significantly less. And we have and we think that's contributed a lot to the injury to the small bowel, so there's less likelihood of ileus. We also give them a liquid diet immediately after the procedure. Some patients, if you stress them with a significant food bolus, we find that can be a problem and cause pain. So we reduce the time of procedure. We give a liquid diet until the next day. And we also give them some antispasmodics. Here, hyoscine or Bentyl is something that we use. And I think this use of CO2 insufflation is really important. So the other things is the mistakes or errors is perforation is a big issue. It doesn't happen very often, but I'm going to go some of the mechanisms of injury. One is the tip of the scope. You have to remember that your ability to apply force to the tip of the scope is significantly increased because if you're using an overtube, you can apply more pressure to the tip. So you have to be more aware of that. Adhesions are also a significant issue. A few papers have been written which have shown that the adhesions have caused tears or perforations, and that can happen in two ways. One is there can be a sharp corner that you try to go around, and the tip of the scope can perforate there. The other is when you are shortening the scope, if you pull in the adhesions, that has actually caused a perforation in at least one abstract was written about that. Dilation of strictures is a significant issue. I'll talk about that in at some length in coming up. Polyp removal. Most of the polyps in the small bowel are not are hematomatous and have a low malignant potential. So we use a little bit, we leave a little bit more and try not to get too close to the small bowel wall due to the thin nature of the small bowel. The other is what happens occasionally with perforations with hemostasis. And I'll go through each one of these because I think it's worth learning from. One is avoiding the complications of deep enteroscopy from the tip of the scope. Those injuries, that happens sometimes at the ligament of Treitz. That ligament of Treitz here is fixed, and occasionally you can push through, and we've seen a few injuries at the ligament of Treitz. My recommendation is to use great care and don't push against resistance through the overtube. Injecting water can be very helpful to help you surf around the corners. That water creates a little space between your tip of your scope and the small intestine. It can be very helpful for straightening and getting around corners. You also have to recognize the locations that are high risk. The ligament of Treitz, if tissue is inflamed or you have post-radiation enteritis, these are the areas that you can run a significant problem. So this here is obviously not an endoscopy, but it's going to be a combined enteroscopy, a laparoscopy. And I'm showing you this here because I want to show you how dense adhesions can be. These are the omentum in the small bowel tacked up against the wall. And if you're trying to pleat the small intestine, that's just not going to happen. The small intestine is, if it's fixed in places, it can be very difficult to manage with the deep enteroscopy. Here, what you'll see here is there's a tattoo, and you're going to see what it looks like on the other side. So this is the tattoo on the other side, and there's that adhesion. We couldn't get past it, so we're going to free that up and try to get past that. You have to avoid pulling back with the overtube against resistance when there's a lot of adhesions, because then you can put a lot of stress on this area, and you can actually cause a perforation. The spiral holds the most, the double balloon the next, and the single balloon is less likely to cause a problem with that. So from patient's history, you have to remember that sometimes pleating of the small intestine may not be possible unless you have the assistance of your, and there's the small intestine pleated on the enteroscope there after it's all been mobilized. So occasionally combined laparoscopic procedures can be necessary when you have these adhesions. The other thing is strictures here. What you'll see here is we're going to dilate this stricture. This stricture has a moderate degree of inflammation. We will be very careful about overtube advancement through this. One of the lessons I learned the hard way is you should not put overtubes usually through the strictures. We push the scope through and we'll dilate them, but particularly with the spiraling through these strictures is not a good idea. So we're very careful. We select those lesions that have the thinner, non-inflamed strictures, and those are the ones that most amenable and least likely to run into problems. You see, this is a relatively narrow diaphragm of a stricture, so this responds pretty well here. But you need to show great respect for the potential for perforating the small bowel. We always try a little bit less with that. Removing polyps is obviously an issue. This is a very, very favorable polyp to remove. It has a long stalk. We'll remove that stalk. We'll cut this off just below the polyp head. In those flat ones, we always leave a little extra. And we will often, they'll often be juvenile polyps or hamartomatous polyps. These have low malignant potential. So leaving a little bit of tissue is often not an issue. And there's more benefit to it than the risk of perforating the wall. So we tend to be a little less aggressive due to the thin small bowel wall, and we often place clips at the base of our resection. So we've also seen perforations with the APC. The APC is non-contact. You have to make sure that it's contact. Occasionally, we've had, particularly with the very small, the 1.2 millimeter APC probe, we've had people perforate, push accidentally, press and push it through the wall, and we've had some small perforations from that. So non-contact, low wattage, and we like to use what we call effect 1. I'm not sure if you have the same on the Irby settings there, but the effect 1 gives you about 1 shot per half second versus the effect 2, which has approximately 20 shots per second. So we like low wattage and a low number of shots. Bicap cauterization, we also use low wattage, and we try to limit the pressure due to the thin wall. And we often use mechanical clips or compression in addition to our hemostasis. So I'm almost done now. And the other thing I just want to mention is what do you do when when you're done and you can't find the bleeding? It can be quite frustrating. Or where is it? You can't find it, and you've looked hard. Occurs in about 20 to 40% of cases. And what do? Well, we reevaluate that whether we're looking in the right place. We've placed a tattoo so that if we need to have a capsule we placed in the future, it can be helpful in directing therapy. When bleeding is suspected, we do an urgent capsule or an urgent deep enteroscopy or a CT angio, depending on the clinical situation. So I apologize for running a little bit over time, but I do thank you, and I look forward to getting back to Brazil sometime and seeing my friends. Are you there?
Yeah, thank you, Paul. I'd like to invite Dr. Admar Borges and Dr. Paula Polet to start for the discussion. Paula, please.
Hello, thank you so much, Professor, for your talk. Excellent talk. I would like to ask you, what do you think about doing enteroscopy as the first diagnostic tool for a bleeding? We know that the patients with hemodynamic instability need a fast diagnosis. What do you think about it? You prefer enteroscopy or you prefer angiotomography?
Yeah, so I think there's been good studies. Our dear friend Laura Gerson did a number of studies with, it was shown that the cost effectiveness of urgent small bowel of deep enteroscopy. So when I can do it, it depends on the situation. If I can arrange it and it's a brisk bleed, then deep enteroscopy I think is a cost-effective and reasonable way to go. I think we see as a referral center a number of different patients in different scenarios. And the nature of the small bowel bleeding tends not to be quite as torrential. So we do see them more likely in a chronic situation. But in those situations where we suspect a small bowel bleed and we have access to our anesthesia, there are limitations, logistical ones, with our anesthesia and our team. So if those can all be overcome, then we will oftentimes go to a deep enteroscopy, particularly in those cases who we have been searching for it and we're trying to find the active bleeding. We'll often go right to that. It all depends upon the clinical situation, but I think a early first use deep enteroscopy is a reasonable approach.
I agree with you. Sometimes it's very challenging, and we don't have too much time to do many tests, and we have to go to something that we can do therapeutic and helps our patients. In the different societies, they have a different guidelines for doing that. What do you prefer to do? You prefer to do the deep enteroscopy with double balloon, with single balloon, or the spiral in these cases? What do you think about?
Yeah. So in ARSA, we have technical limitations. We can only do the single balloon or the spiral enteroscopy. I think if you look at the data, all of them are relatively equal as far as diagnosis and therapy. But having said that, I think my clinical suspicion is that if I have to go the furthest, the double balloon it will get you the furthest. I think the single balloon is the least. I use it for the patients who is the least traumatic, in those patients who have multiple surgeries, perhaps adhesions, who have some narrowing or have some eosinophilic esophagitis. I like to use the single balloon. So I like to have different techniques for different situations. I think the spiral enteroscopy has real advantages in terms of therapy. The spiral itself holds very nicely and allows you to stay in position and do your therapy. So I've been very happy with that. And I said I wouldn't mention the motorized version, but I will. The motorized version allows, I think, is better than all of them, and I think, but we have run into some FDA issues here, and the COVID crisis has made it a lot worse. It makes everything worse. But having said that, I think that different tools you have slight nuances of for which one I use in which situation. And it also depends on what you're technically available. But no matter what you have within the single balloon, double balloon, or spiral, if you have it, then the data will say that you will find most of the lesions with that technique, and you just become a master of your own technique and whatever modality you have.
Thank you so much.
Congratulations to your outstanding presentation. And we know that the first spirals, there are many cases of perforation. I know you are very involved with the second generation project. So I'd like to ask you, do you think the second generation spirals has overcome this problem, totally overcome?
You mean the motorized one?
Yes.
Yeah. So I have followed some of that, and I don't know about. Oh yeah. every issue that has come up. I think it is a new technique, and it is deceptively simple. You put it in, and it requires no new skills, but it requires a new type of thinking when you're using it. So I think that how people use it and the learning curve is important. So it's hard for me to figure out a little bit whether part of any complications are a learning curve, and part of it whether it's can be overcome with better training. So I have not, the numbers I've seen have been in the order of 1 to 3% in terms of complications. So I have not seen a high complication rate from the data that I've seen through without going too much into, because I see some of the Olympus data. So I have not seen a higher perforation or complication rate than that. But I will say that I think the technique is a very powerful one, and we have not had with the overtube that we use the overtube is higher and stiffer. We have not had a higher perforation or complication rate. So I'm not quite sure what the numbers you're alluding to, but the numbers I've seen have looked within the range of the complications of DBE and in particular DBE and single balloon. So
I appreciate your explanation about the patent capsule. I'd ask you, what is your criteria for using patent capsule? I mean, in fact, you select the patient with the CT enterography, EMR enterography before, and then you select subgroups and patients with stenosis and pre-stenosis dilation. This is the patient who fit the criteria to patent capsule. What do you think about that?
Yeah, let me go right to the end. I think I think my judgment is good, and I think that the patency capsule is helpful. But even saying that, you still will have capsules get stuck. So I think it is helpful to do this, to do the patency capsule in patients who I have a clinically suspected small bowel obstruction. That could be because of symptoms, where they have present with symptoms of small bowel obstruction. One or two, if they've had surgical changes within their to their small intestine. So I think that those patients who have had surgery, I usually get a patency capsule. For those patients who have Crohn's disease, I have to prove to myself that they do not need it. Otherwise, I usually give them the patency capsule. So they would have to be very asymptomatic and for me not to give them a patency capsule. So I think that's my approach in general. Is patients who've had surgery usually get a patency capsule. Patients who have Crohn's usually get a patency capsule. Anyone else who I think has symptoms gets it. I try to be selective. And even despite that, I'm wrong.
I have a question for you. Which of the single, double balloon, or spiral model do you consider the easiest to use and with the possibility of reaching the terminal ileum?
Yeah, I mean, I think that the easiest to use is a single balloon. My clinical experience is it doesn't go quite as far. I think that the spiral goes a little further, and I think in my experience, from what I've seen, the double balloon has the most potential to go the furthest with the most work and time and effort. There's with the overtube spiral, you are limited by the length of the overtube, and it just can't pleat that much. The motorized version, I've consistently seen the entire GI tract with that, with an above and a below approach. In our experience, we have not had any complications from that. But I think that that's a highly experienced person who is using the technology. So I think that if you want to see the entire small bowel, that the double balloon is the way I would go. If you were concerned about patient who had the least, you wanted the simplest, then the single balloon. And if you were using the single balloon, I would tell people that if you look at the data, your finding of lesions will be just as high, and your treatment of them will be just as good. So the data supports using all three, although I think there are subtleties between each one of the modalities.
Paula, your last question, please.
Professor, is there any patient that you contraindicate the enteroscopy? A patient with too many surgeries, a patient with using anti-inflammatory drugs for a long time. Is there any patient that you contraindicate?
Yeah, I mean, I think that those for the deep enteroscopies, I'm willing. I think that what I alter more than whether I is for contraindication. Most patients I will do it unless they have mucosal bleeding issues, cannot get off of anticoagulation. If they're on, I will still do it if they're on anticoagulation. Although I may use something like a single balloon more often because I find it less traumatic. I think what I do alter is my style of most in those patients who I suspect have adhesions or strictures or post-surgical. What I alter most is my technique. I tend not to be as aggressive, and I think that's where most of my changes happen. So having said that, people with who have tight strictures, I think I will avoid using. So stricture would be the most common thing, and particularly esophageal strictures, tight esophageal strictures would be the biggest contraindication.
Adimar, please, your final question. Adimar.
Okay. And Paul, could you give us a tip for ileal intubation?
Sure. I think it depends on the. So one of the things we found very helpful is doing a colonoscopy beforehand. We do the colonoscopy for a couple of reasons. One is I think we clean out the entire colon with the 2.8 millimeter suction channel. It's hard sometimes to get it really cleaned out well, the colon. So we do a colonoscopy, we do a good clean out, and I think that's very helpful for visualization. So I think being able to really visualize is important. We also straighten it out. I think that for the intubation itself, my sort of approach to it is I try to get the my overtube into the ascending colon, and then I try to grab it, lift it up, and slip in, and that's so. I think that is what I'm thinking about. If you just push, it tends to bow into the cecum, and then it falls out, and that happens repeatedly. So I think you have to go in, lift the lip up, and slip on in. That can be challenging. Sometimes what I'll do is I'll put a biopsy forceps through to add a little stiffness to the bending section, so that when I lift it up and go in, I find that helps with the cannulation of that. I think the other thing you can do with the single balloon is sometimes blow up the balloon on the overtube and sometimes slide it down. And sometimes that can help change the angle a little bit with the balloon up. I've had less success with that. But the thing I have the most is making sure you can see really well by really cleaning out the colon well, so you can really identify where you want to be. Number two, using the biopsy forceps to stiffen that very flexible tip. And then the other one is just grabbing it, pulling back, lifting it up, and trying to slide it in. So that's my usual approach.
Thank you.
Paul, we are finalizing the session. I'd like to thank you, our moderator, and you for an excellent presentation. And the final question for you, what's your message for those who will learn the enteroscopy technique?
For the people who want to learn, you mean?
Yeah. What's your message?
I think if you're an endoscopist, particularly if you like to do therapeutic endoscopy, then you need to do everything. You need to more people need to take the time to be good therapeutic enteroscopists. I would like to see more people view that like they do ERCPs and EMRs and everything else, and become a therapeutic enteroscopist. I know that it is challenging. But it's very rewarding. We found a lot of terrific pathology, and I think more people should take up the challenge.
Thank you so much. Paula, você pode dar a sua última mensagem, na sequência o Admar, por favor.
Eu gostaria de agradecer à comissão organizadora pela honra da moderação. I would like to thank you, Professor Arkman, for your brilliant talk, and I would like to invite everyone to our course in SBAD of enteroscopy and capsule endoscopy. Thank you so much.
Admar?
Congratulations, Paul Arkman, for your brilliant presentation, and thank you, Paula Polet, for your comments. Thank you, Eduardo, for inviting me and Sobedi. I'm very honored. And thanks to the audience for sharing this event with us and for their questions.
Thank you. Bye-bye. See you next week in a new event from Sobedi. Thank you, Paul. Remember, next month, I will interview about your contribution for the endoscopy, okay? Bye-bye. See you later.
Ciao. Thank you, everyone.
Thank you so much.